Okay, so if you've ever been to an event like this with us before, you know that we always have an open Q&A session, so ask the experts. If you have a question, put your hand up, we'll try to get to you. When can you ever have this panel of expertise to ask questions to? This is amazing. Thank you for staying and taking questions. And if you are watching online, we know we have a lot of viewers online. If you want to put something in the chat, we'll try to ask those questions for you. Does anyone want to go first?
Okay, my question for you, since we were talking about the differences between NMO and MOG earlier, what percentage of patients now that are diagnosed with MOG came out of the NMO community that were originally seronegative?
It's like a trivia
Or do you have a ballpark?
Well, historically, everything is lump sum under MS umbrella, and then there's a NMO spectrum disorder. So among those, you can imagine 70 to 90% are aquaporin 4 positive. Among the rest, seronegative, aquaporin 4 negative patient, only 1/3 is MOG positive. And then if you do the calculation, and so there's still a group of patients that is negative for both MOG, aquaporin 4. So those are called a double seronegative patients. Still remain to be discovered. Maybe there's unique antibody associated with this subgroup of patients. It's huge interest of us. Yeah. Thank you. Mm-hmm.
Yes, my question is, I had a severe brain relapse in 2022, autoimmune encephalitis, and it wiped out my memory, and I'm still trying to work on it. How long does it take for the brain to heal?
Okay, do you want me to take this too? So usually I tell patient, so brain does have ability to repair. It can take a year to a year and a half. In general, after stroke or MOG or other immune or non-immune mediated attack. But it really depends, is the initial events still driving the process, or are there comorbidities, we call comorbidities, it's coexisting medical conditions that continue to make things worse, such as sleep issues, mood, and other medical issues, even anemia or thyroid condition. So all of those compound how you feel from day to day.
Well, I had insomnia for 4 months, and they didn't know how to treat my insomnia. And that started from a relapse of hearing loss. I went to see my ENT doctor. They did an MRI of the inner ear canal, and they saw that there was an attack there. So they gave me a taper of prednisone, and I got insomnia, and it didn't stop for 4 months. And then finally, they said, let's do an MRI. They were trying to say it was psychiatric, and it wasn't.
So there could be lesion that cause insomnia. So it really have to look at the brain lesions, and if you want to chime in.
Yeah, I will just say I'm sort of, I always like repeat myself, but like sleep is so important that many times if there is any concern about sleep being, part of the mental fatigue or the physical fatigue, doing a dedicated sleep study can be really, really important. Of course, they would look for things like obstructive sleep apnea that many of us are vulnerable to, but also if you've had brain-related attacks, maybe central sleep apnea, and the treatment strategies can be different. So, but yeah, I would agree that, probably a year and a half, the kind of outcome based on inflammation that should be sort of gone, and you kind of know what your new baseline is. But like Dr. Hardiman said, I think a lot of the things is like what is within your control. Like you can't undo the nerves that have been injured, but you can try to, modify your sleep or try to move a little bit more. And I think those things often can be really helpful. And knowing sort of your range of like, this is what a good day really looks like, and this is what a bad day really looks like. If you know that you can have those good days, I think that can be a goal. If you can, piece by piece work on sleep, diet, exercise, that you get, more good days than bad.
And I'll just add, we talked a little bit about the gut microbiome and all the microorganisms, primarily bacteria in the gut. Those can become deranged with medications like steroids. And so that's one of the areas to look at in terms of getting benefits. And also, there's a whole slew of viruses that live inside of us. They're called chronically infecting viruses like herpes viruses, like Epstein-Barr, and others that can awaken when a person has had a relapse or has had another kind of inflammatory attack. And when these viruses reawaken, they can lead to persistent inflammation in the body. And paying attention to those aspects can be also really important to sort of put these viruses back into a sleep mode.
Could you maybe follow up on the Epstein-Barr virus, that meaning like if someone had mono previously, that's something that may be latent in their system?
Yeah, so there is a huge association between Epstein-Barr, a virus that can cause mono when people are having symptoms. But Epstein-Barr is also really common in the general population. Over 90% of us have EBV. And the way that we get it can be as simple as drinking from a glass that someone else has been drinking from, and a little bit of that saliva, infected saliva, can be left over, and we can get the virus and be asymptomatic, meaning that we may not even know we got it. And depending on when people are exposed to the virus, determines risk for autoimmune diseases. So EBV has been shown to be a major marker of disease epidemiology in different types of autoimmune diseases, including in demyelinating conditions like MS and NMO. And this virus, once we get it, stays in the body forever. And when it reawakens during times of stress, relapses, medications, sleep deprivation, surgeries, any sort of stress on the body, it can really contribute to increased inflammation and increased symptoms, and can affect sleep and can affect our gut's ability to function. So it can affect a lot of different aspects of our health.
I have NMOSD, and a lot of times when people tell their stories, they start off with the vision. Mine started with, I woke up and the whole left side of my body was numb. My question is, when people talk about relapses, it's always some part of my body that's numb, whether it's my foot today, my arm tomorrow. How do I be able to understand what is a relapse or what's an attack when that's like my normal everyday?
Dr. Wan and me actually wrote an article about pseudo-relapse versus relapse and how do you tell them apart. You probably know your first relapse symptoms, what they're like. If you feel like these are resembling the initial attack in milder degree, it could be residual symptoms. So there's three things you're looking for. Is this residual symptoms versus a brand new episode, or is this something else that triggered this? So we call pseudo-relapse if you have infection, in fact, increase the body temperature just from going to the heat here in Dallas, 100 degrees weather, or take a hot shower, bath. They can all bring on old symptoms, the residual symptoms, and you have a fluctuation of those symptoms. If it resolves from cooling down, less than 24 hours, then that's probably residual symptoms. Or from rest and lack of sleep can do it, stress, infection, just any number of triggers. So I think if I'm missing anything, please chime in.
Yeah, no, I think that's really, the kind of the two key things are sort of location and timing. So you said, that was on one side of your body. If you had a new symptom on the opposite side of your body, that's not something, you would expect an old relapse to cause, brand new symptoms on the different side of your body. I think that would apply too. If you have optic neuritis on your right eye and then you have left eye pain and you can't see, you don't need to wait. I would just talk to your doctor. But generally, when it's an old symptom that you have sort of experienced before, I think waiting 24 to 48 hours just to sort of ride it out a little bit. If you, develop a cold or flu and it's like, okay, that makes sense, then you can say that's probably an old symptom. But still tell your medical team. They will, ask more detailed questions. They may bring you in to do an exam. If they're still not sure, they might do some imaging. So that's sort of the process, and that's why there's probably not a rule, hard and fast rule for everybody. But I think the more you know your body, what you've gone through, know this is like something I've been there before, and this is this is what it felt like. That's helpful to know. I think with children, it's sometimes difficult because we often have to train parents to really know, these are the subtle things. But since, you've had that lived experience, I think you'll know something if it's never happened to you. But then also, I think I have to warn family or patients, there are other things that are not your neuroimmune disease that you still can have, aches and pains. And sometimes it's just arthritis, or sometimes it's just neuropathy from, getting older. So I think the nuance is always there, and talking to your doctor and having them know you and you know yourself is really important.
My question's for Dr. Wang, and if anybody knows Corey, this is Corey's amazing neurologist, Dr. Cindy Wang. But as Corey gets older, I know that obviously NMO is not a progressive disease, but she has shown kind of like what she was saying, not new symptoms to her, because Corey's had attacks pretty much everywhere, but new symptoms more. As she gets older, she has more symptoms that and I don't know, it could be age related, like her not telling me when she was younger. But more that I've noticed as she's gotten older, things that bother her, or numbness, or just newer things to me, I guess, maybe. And it may not, like I said, it may not be new to her, but as she gets older, can things like that happen? Because she is growing and things.
Yeah, I think absolutely. I think that, again, I see a lot of pediatric patients without neuroimmune disorders. And, there's certain ages where I know to ask certain questions, like you're a teenager, you're probably not sleeping. So, if you tell me you're getting 4 hours of sleep, that's probably one of the reasons that, anything would be worse. I think there's social pressures that this young generation has that, that I can't even imagine. So I think there's certain points where there's more psychosocial stress and maybe feeling a bit different. Maybe, at age 2 or 3, you don't really understand that you're in the hospital, you have a disease, but now you can see, well, all my classmates didn't have to do this. They don't have to get infusions every few weeks. So I think there are things that as the brain and, develops and other things are added to someone's plate that, it can unmask old symptoms, or there can be, more of a mental health component to symptoms. So yeah, having that support is really important. But I think that's really why, we have a neuropsychologist in our group, which is really wonderful to sort of understand and test children every 1 to 2 years about, where they are. This is more kind of just, you're not doing algebra when you're in kindergarten, but now you are, and it's a lot harder because those are not things that come as easily to you.
Hello, I have a question about exercise. So I started going back to the gym, but every time I get ready to stretch or something, I go immediately into a spasm. what can you suggest? I've tried micro movements and things and like, okay, I'm gonna build up to this. But then when I get there, it's like I start back spazzing really bad. And my neurologist, I'm from South Carolina, so my neurologist is like, just cut it out. Just kind of sit at home, which is not always the greatest thing to do. But I understand where she's coming from because my tonic spasms really hurt. They are not comfortable for anybody.
When I have patients who describe that exact situation, what I found has been, I guess I'm blessed. I work with a very knowledgeable physical therapist as it comes to these neuroimmune conditions. So I actually tell patients, let's set up a visit with Heather, that's her name, and she will demonstrate different types of spasms that you could try that will possibly prevent from going to the spasms. So she's able to help you identify which muscles you're possibly triggering that are causing the spasms, and then she can teach you a different type of stretch to do so you can accomplish what you're wanting is to stretch and it's needed without causing the spasm. So if you can research and see if you have a neuro PT. So as with all aspects of medicine, physical therapists are getting even more subspecialized. So if you can find someone who is a neuro PT that are trained on more of these different types of conditions, MS, NMO, MOGAD, and can understand some of the nuances that come along with that as compared to like having a stroke. It's a different way of doing rehab. And so you'll get more of those different answers you're looking for.
And other aspects to just keep in mind is that spasms may increase in frequency if you're tired, if you're dehydrated, if you haven't been eating well. So keeping in mind, maybe planning a little bit if you're going to exercise that day, really making sure that you're on top of all of those really important baseline aspects of your health, and just drinking a ton of water with electrolytes.
I could add to that. She mentioned chair exercise, and we also have a program called Adaptive Yoga. If you Google online, it's Adaptive Yoga. It's designed specially for MS. And there's a special movement that can trigger spasms versus oppositely will relieve it. If you could check those out. It may be also helpful, I found, at least for myself, not to embarrass myself. I don't like to work out with a group of people. So if I just do it at home and quietly at my pace, I'm fine. I'm not in a superstar group and they've been doing yoga for 10 years. I feel really, really clumsy there. So that may also relieve some pressures and stress. Do it at your home time, like whenever you feel like.
Hi. I have a question in regards to being seen in the ED with NMOSD, and I've noticed that in the last year or so, the neurologists do not want to treat you. Even if you're having an exacerbation, they'll tell you that to see your neurologist, that because it's a chronic illness, they won't treat it in the ED. They say go to your neurologist. And in my case, I went to 3 different EDs, and they kept saying, oh, it's chronic. But here I am having new symptoms, the numbness. I was falling, and I couldn't even lie down without even being in extreme pain. But they kept saying, see your neurologist. And I want to know, what did you do in those instances? Because my neurologist, they gave me an appointment for June 1st. And I'm going to say this. I had to call in favors of a friend. I am a disabled nurse. And I had a friend come in and give me steroid injections, or infusions rather, at home. And it wasn't until I got those steroids I began to feel better, and all those symptoms are lessened. But I'm still fighting having the versus pseudo flare versus an actual flare. And the doctors didn't even know what NMO was, but they just dismissed me. And one neurologist said via the ED doctor, oh, she's not having a stroke, then we're not going to come and see her. And that wasn't just one, it was several.
So sorry to hear, about that experience, whether it's through AI or just other education programs. This is a rare disease, so we are trying to do what we can to educate, primary care physicians, even other neurologists, ED physicians about, the urgencies of an NMO. And, it is, a very treatable, it is a chronic disease, but it is a very treatable disease, right? So I think, just doing what you're doing, advocating for yourself, has tremendous value. As you're kind of engaging with the health system in different locations and things like that, unfortunately, you may be put in a position where you may need to tell, the emergency doc a little bit more about what NMO is. And that does, that is a little unfair to you, right?
I've done that. And generally, because you know more about your disease than they do, most doctors are saying, oh, but a lot of them become very defensive and very dismissive. I've even been told, okay, it's anxiety. You're anxious. We're going to give you some Xanax. I'm like, I don't need Xanax. It's not anxiety. It's not a migraine. And one doctor told me it was a migraine. And just to placate him and to maybe get better treatment, I took the Fioricet they gave me, which made me nauseated and lightheaded. And then they told me, you know what, you should try marijuana. And I'm like, well, I already have that. And it works great for those spasms. I just want you to know.
So thanks for sharing your advice and your experiences. I guess the best piece of advice is do what you can to advocate for yourself, and if you're not feeling like you're getting the best care, we always encourage second,
I
third.
want to ask, even like before, if there could be a protocol for NMO patients that y'all could just kind of send like a memo to various hospitals, and not so much as educating the doctors on NMO, just telling them that time matters. It's almost kind of like a stroke, in my opinion. The sooner you get treatment, the better I heal and the better I rebound from that. But when I'm denied treatment and I'm talking to them and finally someone gets it, by that time, I'm back paralyzed on my left side, I'm back in the ICU, and then I'm back again in inpatient rehab for weeks or months at a time.
If we had like a protocol, whether it was through AI or otherwise, that would be wonderful, right? Because I think that would be, that would help deliver care faster. And to your point, we do think that there's some urgency for relapses. The problem is, everyone's very different and very unique. And if you really define it within that bounds, you're going to probably lose some folks, right? So, you engaging with folks and talking with folks is still kind of the best way that we've got to help folks in your shoes. So, it'd be if you have a creative idea, I'd love to hear it. Yeah.
I've been thinking about a lot of things, working with my neurologist, and actually my neurologist is one of the teachers, and I went to the hospital where she teaches, and she put in her notes specifically if I ever come into the ED to contact her. And a lot of doctors don't. And case in point, she came to visit me into the ED in one hospital, and the physician kept saying to me, oh, I contacted her, she's not responding. And it pissed her off to the point where she was actually using profanity because she said, I'm the so-and-so that you said you called, and I'm sitting right here. So I don't know, what to do, and I try to advocate for other patients who have MS and NMO to tell them how to talk to the physicians, and it's not working. Even with pain, they think that you're drug seeking because you're having pain with the NMO, and it's like, oh yeah, she's a drug seeker. And I've even told them one time in a relapse, yes, I am drug seeking. I want the steroids, and I want the pain medicine. I do.
I'm sorry, may I ask a question? So this is something that has come up before, because it has happened to, I think, probably a lot of people, even in the room and online. It was suggested once at a different event that at discharge, when a physician has to do like a discharge summary anyway, is it possible to talk to your doctor about writing something about best case, like how they should behave if they feel like they're having a relapse, like some sort of like steps that people can take, and they can take that paper with them. Like if you feel you're having these symptoms lasting more than 24 hours, and then the protocol that would be used for a relapse in case they had to go to the ED, and they would have that then. Like, IV steroids or contact me or something like that. Is that something that you've had in your own practices or no?
You know, I think with the AI these days, I do tend to type a lot more. Not just me, actually, for surgeons. I mean, they never type any notes, and I start to see their notes and 2 pages long. Something's wrong. AI either doing its job or not. But for surgeons to type that long notes, but we do have a discharge instructions. So if you have experienced X, Y, and Z, I have like long discharge summary. I don't know if you all read the discharge summary, you doctor type. You probably throw it left in the car after you leave our office. You probably never paid attention. But there, just to be completely honest and transparent with you, sometimes it's harder even for physicians to tell if it's a true relapse or pseudo relapse or what we should do, because we can scan you from head to toe, optic nerve, spinal cord, different segment, and MRI whatsoever. It's still miss lesions because the lesion can be so tiny. So I think you're advocating for yourself sometimes is really worth it, because we can't practically scanning every piece of you every time you complain each symptom. So insurance is not going to approve it. So there's a lot of practicality issues, and we're not God either, and none of your physician is God. Sometimes there is actually honesty and just a gray zone, and nobody could tell. And sometimes it probably just take initiative to say, let's give it a try. I mean, steroid, if you tolerate okay, just we can give it a try. You just have to say that, And if your doctor's not hearing you, and it's probably time to switch to somebody else. I mean, I have to say that because it's my own experience too. Just, someone will be willing to listen to you. Okay?
If I may mention everyone in the room, through Patient Health Alliance, we have 2 programs, the Merit Alert, if you can order it through the website, or through Corey and Kim. And also we also have a patient card that you can carry with you. If you go to an ER, it will show what your symptoms are, so what your diagnosis is.
Right. And the NMO Resources app still exists as well. I know, Dr. Hardiman, were you going to say something? I think.
I was actually going to say what he said. I remember back in the day, there used to be different cards that patients could print off and carry with them to say, I have this rare neuroimmune condition. It presents with these type of symptoms. It can be very aggressive. This is what to do. And that would help because right, ER docs look at things as they're trying to identify something that's life or death. And while, yes, NMOSD can be, people can die from it, they're not trained on that to view it as a life or death situation. They're looking for those acute things. But that doesn't dismiss how you've been treated and everything. And so it is to advocate for yourself at a bare minimum. Just ask, can you do the MRI and see if there's changes? And if so, they are more likely going to act on those changes and everything. But I think the card that Patient Alliance has been very helpful with patients, especially those who live in smaller rural areas where they may not have a direct access to a neurologist to come in, evaluate them.
Yes, and right here, so if you did not pick up one, and we might not have enough, you can reach out to us. There are some cards at the table, or you can make your own that look like this. And these are those acute, the quick, what is NMO? Because I've had to use it recently when I was in ER just a couple of months ago. And not just a card, but after same thing, saying one thing or not knowing. But the biggest thing I want to take away, and thank you all the doctors, is that for you, Keisha and others, now you have a whole group of patient advocacy council people and yourselves. You can stand up. You have people that we have combined to help. And I am so happy that, I've been able to do what I can to assist people. So I wouldn't know if you're having a problem. Please reach out to this organization to see if we could help by writing letters, by advocating with you, by getting your aftercare summary, or also not dismissing any of these wonderful doctors. But yes, there are some out there who don't have the empathy or didn't, they're just, straight with different things. But how we can help advocate by going to, like we just did, I'm going to stand up and talk about the hub, but we just went to Washington. And so this is Keisha. She's also my co-facilitator for the women's group. And we're going and we're trying to get these different initiatives. That's on one hand, but we want you to take a breath when you're there in these offices, and I'm not saying you, but because I can do it too. But the decorum. So there is decorum, but there is, and we get these forms. I get them at my house. The minute you've out of the office that came in the mail. Oh, we would like to know how your experience was. Oh. You really did. So take that opportunity to fill those out and send them back. And it does make a difference. And if you don't hear from anybody, go to the next level at the hospital or the facility that you're at. But I have a lot of, want to talk about that another time, I know. But you want to talk about really quick the hub thing?
So in Washington this year, we've been going the last 3 years together. They are thinking about, they're trying to put together language for a hub. The hub is going to be more or less for rare disease patients. It'll be language that it says, hey, this is what NMOSD looks like versus MS. So that is something that is in the works, but you have to reach out to your governor, reach out to your senators, all of your representatives, and there's an awesome group that we follow. So it is Every Life Foundation and RDLA, Rare Disease Legislative Advocates, and that's who's working on those things for us with the FDA. So if you guys don't mind, if you have questions, write them down. We do this every year, the last week in February, Rare Disease Week. Go out, let them voice what's going on, because they don't know. Right. As we all know, rare disease affects just a small, actually a big percentage, but it's a lot of different rare diseases. I think it's 10,000 of them. So it will not bother them unless they see people that's going through things. I have my local senator. He's like, Keisha, how's things going? I remember when you told me the story about how, this, and this happened, just like you, Keisha. And he remembers that. So now that's one more person that knows about NMOSD. But there is something in the works for a central hub with language for rare diseases.
Thanks for sharing. I have a question in this end.
My name's Kim, and I guess mine's a two-part question. When I was first diagnosed, I had lesions on my neck spine and then down my spine. And maybe about a year and a half later, my neurologist, he was a bit surprised, but he said that the one in my neck had healed. So my question is, can lesions heal? Have you seen those heal? And then with it having just been there, does it still possibly do something to my vagus nerve? And of course, I am a Dr. Google, so forgive me. But I've been trying to, learn just the definitions, not for a diagnosis about that nerve, but could that nerve still be impacted even if that lesion had healed?
And can I ask you, do you have NMOSD? Oh, okay. I would say, in MOGAD, a lot of times the lesions we see, like in children and young people and adults, do heal. They go away. So it's probably not irreversible damage. It's probably edema or swelling. But I think the same applies with NMOSD, especially if you catch it fast enough and you get the treatment enough, then I don't think that tissue is irreversibly damaged. And then I think many people come from a background of taking care of MS patients, and those lesions often do not completely go away. So that might explain a bit of the surprise if that person's looking more from an MS lens. But yeah, I think, to the other kind of question, like, what do I do, like, during the like sort of crisis mode when I'm worried about an attack? And I'll just say that sometimes in addition to having a card and like having, this is my doctor, this is how you reach them, if you don't know anything, call them. I think doctors, like, our egos are sometimes pretty fragile. So like, we don't like to get more information, like hear information sometimes from patients that, but a doctor to doctor conversation will often get the job done. So I often recommend that. And then sometimes when I see patients or they want to like go on a trip, it's international, they don't know where their, big hospital is going to be around them, I send them with some steroids, because that time when you're in crisis mode is probably not the time to have a nuanced conversation as a pseudo relapse or relapse. But if you get a huge dose of steroid and it wasn't an attack, I don't know if it's that bad unless you're doing that a lot of the time. So I think those are some of the practical things I just like to impart on people. Like, have an emergency plan and talk to your doctor before the time of emergency. That often will streamline a lot of things. And then, for people who don't live near a big community hospital, I know some of my patients, they've educated that, like, that city will never not know what NMO is. So, you guys are doing really the hard work, and, but hopefully, even if they didn't know the first time they heard that condition, they will now. And if they are a good doctor, they will try to, get out of their comfort zone and learn more about something they don't understand.
Yeah, and to your question in terms of the healing, so there is this aspect of swelling that happens in NMO because the water channels are involved. Aquaporin is a water channel. And so when with steroids or with immunomodulating therapy, the lesions can shrink. But sometimes they don't completely go away, and we may not see it even on an MRI, potentially, especially in the spinal cord. Sometimes the lesions are harder to see over time, and we may look at an MRI for a patient and say, oh, well, there's no lesions. But if we look back, several years before when they actually had the attack, we'll see that lesion was there. So it's hard to know whether the lesion completely goes away or there's still some deficit that stays and will interrupt the networks, the communication between the brain, spinal cord, and other parts of the body. And if you have other spinal cord lesions, that network is still interrupted, even if the one in the cervical spinal cord looks like it may have gone away or may not be as clear on the imaging. And it's also really important to keep in mind that different imaging modalities may be better or worse at showing a lesion. So the higher the T on the MRI, the better the visualization will be as opposed to the lower Ts. So that's also important to keep in mind in terms of what type of imaging was done in between.
And then your other question about the vagus nerve, I didn't want to lose that one. So, at least in a sense, by definition, it's unlikely because the vagus nerve is considered, part of the what we call the peripheral nervous system. So we don't see that much involvement in the peripheral nervous system in NMO. Now, that's kind of a trick question because you can have, involvement of some of the things that control the vagus nerve in NMO. We often call the vagus nerve the wandering nerve because it's doing all sorts of different things. It's involved in the microbiome and heart rate regulation, a number of different things. So I'd say it's unlikely, but it's hard to know for certain.
Hi, my daughter was diagnosed a year ago with seronegative NMO. And in the beginning, I was told that to never miss an infusion because it would come back with a vengeance. Her doctor now wants to do 2 years of infusions. If she doesn't have any flares, to start treatment. What do you suggest?
So just so I understand your question correctly, you seronegative NMO? Okay. So, that's a great question because in a sense, we don't really know, at least in my opinion, what the right answer is. and if I had to make an analogy, like we often have a very similar discussion with our patients with MOGAD, because about half of them may be monophasic, half of them will not, sometimes hard to predict, even for those people who have attacks. There's different opinions and not a whole lot of data on, what's the right decision. It's a tough decision, and sometimes we don't know the right answer. So in my mind, that's a little bit more of an individualistic conversation. Kind of depends on what the risk tolerance is, what the medication is that you guys are using for relapse prevention. And sometimes there's clues, based on MRI or blood work on maybe one strategy might be better than the other.
Yeah, I think knowing sort of where you're starting off from, if you've had bad attacks with poor recovery, I think that would change sort of it's always a risk-benefit calculation, right? Being on medicine isn't good. It suppresses the immune system. It may not be necessary in cases of now we know our MOG. Maybe those people will never have had a relapse, and we're just patting ourselves on the back. We're preventing relapses with our medicine. So it's hard to know, but I would say if there was poor recovery, in vision and mobility, motor skills, then I would be nervous and maybe seek a second opinion.
Yeah, and the thing that I'm a big advocate for is shared decision. So none of us have an approach of where I walk in a room and I'm going to tell you exactly what you're going to do. It's a conversation weighing out these different things. Okay, you've had attacks that have, affected your walking, affected your bladder, affected your bowel, or you've just had sensory issues. And so when we go through those different things, look at different MRIs, OCT testing, or whatever the case may be, then yes, we're going to have a conversation based off of these parameters. I think you are a low risk. It may be worth trying. If my patient says, no, that makes them nervous, then we'll just keep doing the medication. So if anything, the take-home message is, if you're not feeling like it's a conversation and you're being provided information and coming up with what's best for your daughter, then yes, it may be best to seek a second opinion.
Okay. As prescribers, I know that based on the 4 medications that are FDA approved, 2 of them are very similar in what their biomarkers are, and then the other 2 are completely different. How do you, as a prescriber, kind of decide what's the best course of action? Since they're all different, is there something in the back of your mind that a patient says that you're like, oh, I think this drug is going to work better for this patient versus the other? And like Dr. Hardiman, you said, shared decision making. Where does that come into play? Is that the main part of it, or do y'all have that in the back of your mind, like, I already know which drug I need to give you?
I am 100% shared decision making. So I will ask patients what's important to you. Is safety important? Is route of administration important to you? Maybe I'll ask, what is your career? And from there, we will narrow down what's going to fit best with their lifestyle. Because I don't want to prescribe something that is going to then cause them problems because it's an infusion and they don't have access to an infusion center or different things of that. So I believe 100% in shared decision making.
So the biomarker part of it, that doesn't ring.
At the end of the day, I want a person on a drug.
Yeah, that's a good answer.
So I do wanted to advocate for biomarker studies, and I think that it's ongoing research, and we are actively looking for, like you said, maybe scientifically predict who will respond to what and better. But we're probably not there yet, especially for rare disease. It's harder to have larger sample sizes. So we have sporadic studies that call for international consortium and collaborations. And so with the AI being more advanced, and biomarkers are going to become more readily available to help us predict treatment response and what treatment to pick eventually. Just we're not quite there yet, but science has advanced so quickly, so maybe come back in a year or 2 will be different. Yes. And another question I was going to address, so for shared decision making, absolutely, because I was really moved by early on with the Val, Mallory, and Andrea, and you are all sharing your stories, just hearing what patients care most and what they want to be out of the treatment, either injection at home or going to infusion, socialize with infusion nurses, all of that above, just make your life more pleasant. And that's all that matters. Yeah, thank you.
Okay, I think we have just time for one more question.
Okay, one more question for you guys. We are in a state where there is a hot button topic right now. We're talking about access to medicine. We already have this issue with the FDA as far as preventative treatments. When it comes to treatments for residual symptoms like chronic pain or spasms, I think a lot of us can agree that medical cannabis is an effective treatment. And Texas recognizes currently MS as a qualifying condition. What do you think about trying to get NMO and MOGAD on that registry? And would your office be willing to collaborate with some of the current cannabis prescribers? And how could we do that together?
I don't know how to politically correctly answer the question. So the first part, yes, and I think in Texas, the registry is going to continue to expand. It's the let's start with this small group, because even when it first came out, it was mainly on refractory seizures, and then they added, or in cancer, and so then they added some more diagnoses and more diagnoses. Where I was saying the political correctness, it's a little bit hard with me being at a state academic institution as far as partnering. There's some process and how I would have to do that through the institution and everything. And so that just brings in, it's an additional red tape and everything. But speaking for myself, I think it is going to happen down the road. It's just a matter of when will that happen.
So really quick, currently there is a submission form on the Texas DPS page to submit for conditions to be added to that registry. But currently the only people that are submitting that are patients and not physicians. And I think that has been a huge stopgap for the NMO and MOGAD community. Does that make sense?
It's a follow-up to that question. Everyone's mad at me because we can't.
So it's not necessarily a question, but a statement. I have actually been approved through the Texas Compassionate Compare program to receive THC through, there's actually 2 pharmacies in the state of Texas that do offer it, but it's just dependent on your provider. Thankfully, I was able to find an office that wanted to take that risk in offering that opportunity for me and other patients, but it is an option. It's just a lot of hoops to jump through.
Oh, thank you for sharing that. Okay, I'm sorry. I know we're a little over, and we have to thank our amazing panel of doctors. Thank you so much for taking your time, for driving in loops around the airport to get here, and for bringing your kids. And they're fine. They were watching a movie. We don't have to. Yes. Days like this really make a big difference in the lives of the community. We learn a lot from you. The presentations today were outstanding. Everyone I know is going to be buzzing about that all afternoon, and lots of questions coming through already on my from the helpline. Can we get the slides? So we're excited to share this with the community, chaptered out. If anyone's watching online, it will be available. It's not just live today. It'll be accessible for everyone to watch later as a resource. I've said this before for some of you that have been to our other events, but none of us in this community asked to be here. This happened to us by no fault of our own. But these wonderful people, they chose to help us, and they've dedicated so much time and effort and heart, and we're just so grateful for the work that you're doing. So thank you so much.